It is
the first one of the whole
this is
year?
the first
First one?
Coffee and Science of the academic year. Thank you so much to Allie and Lucy for arranging all of these things. It's been amazing. It's going to be an amazing set of speakers, including the one that we have today. So I'm thrilled to introduce Dr. Matt Pantell, who's an associate clinical professor of pediatrics in the School of Medicine and the associate director of research in the Division of Hospital Medicine, and kind of a core member of the Center for Health and Community. So, and is like a long time kind of OG guy. So I really appreciate it that you're here to kick this off. So just a few things about Matt. He is a pediatric hospitalist at Children's, where he and he also leads a remarkable mission-driven clinic at Zuckerberg, San Francisco General Hospital. It's our tattoo removal clinic, which I think is so cool. So he's the medical director for that. Providing free laser tattoo removal to adolescents and adults, prioritizing gangs, prison, trafficking, branding, and radiation treatment tattoos. Is that true? ChatGPT created that part. His scholarship centers on the social drivers of health. He's done remarkable work looking at housing, transportation, social connection that shape outcomes, and on social informatics, which is integrating social data into clinical care and electronic health records, which we'll hear about today. His research has appeared in high impact journals, including JAMA, Pediatrics, JMIA, and his widely cited article called The Call for Social Informatics, which he co-authored with Nancy. So that was a really important, and me, and Laura. And it's going to be a great presentation because he's also been recognized by UCSF for excellence in teaching and mentoring awards. He was a pediatric research early career investigator spotlight, and he co-leads system-wide efforts for the UC Office of the President to advance best practices in social determinants of health screening. We're thrilled to have you. Thrilled to call you a friend and a colleague, and we're really looking forward to your presentation.
All right. Thanks so much, Eric. And I'm really excited to see everybody. Yeah, what a great group. So yeah, today I'm going to talk about some of this EHR work and this talk title, Integrating Social and Medical Care Using Electronic Health Records, Progress, Pitfalls, and Potential. ChatGPT also helped me figure out that third piece. So. All right. I have nothing competing to. Okay, so even though this room has probably seen these slides 100 times, and people in this room help make these slides, I'm going to talk about sort of images for integrating social and medical care. I think everybody in here knows social drivers of health, but just for the terminology that I'll be using during this talk, we call social drivers of health things either positive or negative social conditions that are related to health outcomes, whereas social risk factors are adverse social drivers of health like food insecurity or housing instability that are related to negative health outcomes. And then we talk about, especially in clinical settings, social needs, which are social risks for which patients would actually help addressing, which is language that Laura helped develop with Hugh in their paper a few years ago. So I know this group knows that social drivers are related to health outcomes, and then also what a lot of people in this room and Nancy have helped to show is that addressing social needs can improve health outcomes. So in studies conducted by people online, I see Laura there and Caroline, all sorts of siren people. We know that addressing social needs can improve health and can reduce hospitalizations. It's showing a study that Laura and Danielle led, showing that people who had navigators to help address their social needs, children, they were less likely to be admitted over the following year compared to those that were in sort of the control group. We also know that addressing social needs and sort of integrating social medical care can lead to benefits for staff. So it can lead to higher job satisfaction, better perceived quality of care, and then less burnout. So this has led to a lot of standard setting and professional organizations to endorse screening for and addressing social needs in clinical settings in particular. These are just a few of them. That last time I checked still have their endorsements there. And there are also standard setting organizations like the National Committee for Quality Assurance, which creates HEDIS measures, which are quality metrics for hospitals that endorse in the last few years screening for food, housing, and transportation. and also the Joint Commission, which leads safety standards for hospitals, that says that hospitals should screen patients and provide community resource information to them based on social risk factors that hospitals select. CMS used to be on this. I had to take it off. Last I checked, both of these groups still endorse this, as they are separate from the government. And also US News and World Report now awards points for SDOH screening. Even you might not know, but US News and World Report, the thing you see in the magazines, does rate hospitals, and actually it is become an important metric for hospitals and popularity. And so hospitals are now getting sort of ranked on different things related to food insecurity and housing instability. And so because of all this work, there's also been a lot of talk about this in standards-headed organizations, including the National Academy of Sciences, Engineering, and Medicine. Laura was on this group, as well as Kirsten Bibbins-Domingo, who came out with this report in 2019, talking about healthcare activities that can strengthen social care, and talk about sort of the 5 A's framework, which I'll take a second to go over again. Again, I think a lot of you know this, but I think it'll be important for setting the stage for the rest of the talk. So the 5 A's, Laura, tell me if I get it wrong in the chat, if anybody's monitoring. So we have the first one is awareness. So this is sort of activities helping to identify social risks. So for an example, using transportation, it would be screening patients for transportation insecurity so that you're aware of their transportation limitations. Adjustment is activities that I think the clinicians in the room, a lot of us do, but we don't talk about. We just do it automatically, which is adjusting the care to sort of circumvent social barriers, taking the social context into account. So if someone has transportation barriers, then maybe have a telehealth appointment instead of an in-person appointment. Assistance is kind of the traditional thing we think about, where you provide resources to patients that have social risks and want help. So providing transportation vouchers if people have transportation insecurity. And then alignment is activities that where healthcare systems work to understand the sort of social assets of the community and organize them to facilitate synergies between sort of the healthcare system and community organizations. So, investing in community ride sharing would be like the next step in going on the community level. And then advocacy is where healthcare organizations work with the partner organizations in the social sector to promote policies that facilitate better sort of social and medical care integration. So you could, work to advocate for more bus lines that go from places that have transportation insecurity to the hospital and that type of thing. So 5 A's, again, I think a lot of people here know this. Thank you, Laura, for the framework. And I'll sort of frame the rest of the talk related to that. So in terms of how informatics can help integrate social and medical care, Eric had brought up this paper that he and Laura, Nancy, and I, and Julia Adler-Milstein and Mike Wang had written about, talking about sort of the social informatics as the study of applying sort of information technologies to capture and apply social data in conjunction with health data to improve sort of both individual and population health clinical care. And this has become more and more cited over the last few years in terms of, not our paper, but in terms of sort of social drivers of health and informatics and the intersection. This is going through 2019. It's continued to go up since we published this paper. Not because of the paper, because people are interested. So going back to the 5A framework, you could think about ways that informatics can help facilitate the social medical care integration. For awareness, you could think about how EHRs or electronic health records can help, with screening tools and data linkages between different systems. For adjustment, you could think about how to use informatics to create clinical decision tools to support tailoring care plans. Assistance, you can think about how resource referrals to social service organizations can be integrated into EHRs. Alignment, you think about facilitating collaborations with community-based organizations using some informatics tools. And then for advocacy, you could think about using EHRs to retrieve population data to sort of inform policy decisions. All right, so before we talk about the 5 A's a bit more, I wanted to talk about sources of SDOH data in AHR and sort of where things are now. So just in general, when talking about EHR data, we talk about structured versus unstructured data. So structured data is discrete data within the EHR. So this is things that, there are answer fields for, yes, no, numbers, things that have, things that can be words but have discrete choices. So for example, medical codes. So when you go and see a clinician, you go in for a cold, they actually put in a medical code for what the diagnosis is. You can see on your printed papers at the end. And this is from a list of the International Classification of Diseases usually, which has, thousands and thousands of codes for different medical conditions, but it is discrete data, right? They exist and you can choose them from a menu. There are also social determinants of health modules. So for example, this one on the right there in Epic, there are these sort of discrete tools where you can click on, answers to different social drivers, screening questions, and it captures that in sort of a structured form. So you can't type in there, you sort of have to click what the answers are. And then things like metadata, like whether or not certain social care orders or referrals are made. Did someone make a social work consult? You can see that order if it came up in the EHR. And then unstructured data is just largely free text. So this is basically what's typed into notes, or for the clinicians who use Epic, 3 asterisks whenever you're using the Epic, the EHR means that you have to fill in something there. It's basically a blank space. So this is, you can think of largely as just free text and typing whatever comes up. And so the example on the right there is you see like whether or not you click on boxes to indicate something in terms of a social driver of health, or you type in the patient is experiencing housing instability and needs help paying their water bill. So the top would be structured data, the click boxes, the bottom would be unstructured data. And there's pros and cons to each of these. So for structured data, the pros are really for use in population health, advocacy, and research, because it is in a more sort of unified and interoperable form. You can extract that data pretty uniformly across hospitals. All hospitals in the city are using ICD codes, so we can see how commonly ICD codes are used. This is used in COVID research. We looked at those codes. It's used in population health all the time. And then, subsequently, you can use it for advocacy and research to look at certain things. Oop. Still. Oh, no, it's good. Oh, yeah. Sorry. You can use it to say, for advocacy, to say, 10% of our patients have housing instability according to ICD codes, so we should, advocate for more housing. The cons are sort of limited customization. So you're stuck with whatever the structured data, whether it's a module or ICD codes, you're stuck with what the answer choices are. For unstructured, the pros are customization. So you can write whatever you want. The workflow is quick. If you need to adjust something, you can just type it, right? And you can adapt quickly to things. When COVID came out, there was no ICD code for, there weren't as many ICD codes for COVID. And in fact, they had emergency meetings to create these ICD codes for COVID, right? So in the meantime, we're just typing COVID in our notes. The cons are it's hard to extract, right? So you got to look in text to look and find these, whatever words you're looking for. So pros and cons between each of them. For medical codes, again, I talked about ICD. There's also these different codes called LOINC, SNOMED, CPT. These are all sort of medical codes that are used on the front end or the back end, a lot of them for billing, but also for diagnoses. And again, they're easily extractable and interoperable. Shout out to Siren for putting together a list of these medical terminology codes that you can see that are sort of structured data that you can derive from EHRs. CMS, I did look, this is still up there. They also have SDOH codes endorsing these new ICD codes that code for social drivers of health. So now the ICD actually has things for food insecurity and having housing instability and that type of thing. And CMS was endorsing sort of using them to document social drivers of health. This is the sheet they sort of showed you. And here are some of the codes you can see. I know it's small, but these codes, what's that?
Can you elevate your volume? I think the external, your voice.
Oh, yeah.
Yeah, it's hard for people to hear.
Oh, sorry. Hello. Yeah. So these are some of the Z codes, which are ICD codes that are related to social factors that you can see. And again, this worksheet still is up there on CMS, so they have it for people to use. The cons for these, again, are that they're specific, but not sensitive, and they mostly denote a presence but not absence of a factor. So if someone has housing instability, there's a code for housing instability. There's not a code for housing stability. So if you don't see codes for housing instability, you don't know if a lot of people weren't screened or if everybody else just didn't have housing instability. And so when we've looked at this in a lot of different settings, so Jackie Torres did a paper looking at this in 2017, and we did one, and she did one in all patients. We did one in pediatrics, and we saw that only about 1% or 1 to 2% of hospitalizations had these ICD-Z codes, even though we think it's much higher rates of these social drivers of health. And we looked at sort of in California, looking at unstable housing during the perinatal period, where there's estimates nationally of about 4% experienced this, and we only found 0.1%. And similarly, in the emergency department, Mel Molina did a paper looking at this, and only 1.2% of patients had these social driver of health codes, when we know it's much higher in the ED people experiencing social risk factors. So they, if they're there, it's most likely that they are, true, they're specific, but they are not very sensitive. And again, we don't know with them if people who don't have the codes were actually screened negative, or whether they just weren't screened. And so these SDOH modules are a way around that to sort of see. These allow you to click and ask people questions, so you can sort of hover over them. This is a screenshot in Epic UCSF, where all these social drivers are there on the screen here, and you can hover and sort of click on questions that come up. And if you screen positive, these icons will turn reds, denoting that you have the social risk factor, or if they screen negative, they'll be green, meaning that you don't have the risk factor, and gray means you haven't been asked or it hasn't been documented. So you can see these questions come up here on the right, and you just sort of click them. Again, this is structured data, right? So you click and answer, you don't sort of like type in what the answer is. And again, the pros are easily extractable, and you can sort of tell whether something is there, the presence or absence, but then the cons are customization. So for example, San Francisco General did not like Epic's SDOH questions for some of them, so they decided to change some of them. So now if we compare San Francisco General and their questions to our questions, some of them are the same, but some of them are different. So the more you customize, the less interoperability you have. Whereas for ICD codes, they're the same everywhere, but they have their flaws as well. So for unstructured data, so this leads to unstructured data, which a lot of people do. So type in text to the notes. It's great. You can put whatever you want, but the problem is, again, it's not only that it's difficult to find the notes sometimes, but also the text in the notes themselves. And so it reduces the interoperability when you can't really extract this very easily. And just for context, like for example, I'm a hospitalist, right? So in one study that Mike Wang and Julia Adler-Milstein looked at, that hospitalized patients had an average of 147 notes in their charts before they were hospitalized. So this is when they're coming into the hospital, what you sort of sort through to look at their medical history. And so if you're trying to go through 147 notes to see a history of unstable housing and text, it can be very hard. It can be a lot easier if there's a structured way to look at it. And this is just showing how the context may be limited depending on the data source of structured versus unstructured. So Shivani Mehta, who did a project looking at pediatric notes and looking at differences in structured and unstructured data and how that predicted readmission among children that were hospitalized. And you can see, sorry, it's small there, but at the top, this exposed category is those that had a unstable housing or transportation barrier based on ICD codes versus ICD codes and text. So she used natural language processing to look at the text of notes and categorize people as having these based on what was in the text. And you can see in blue, this is looking at the rate of, if you look at blue on the left, this is the hazard ratio of being rehospitalized based on just the ICD codes alone. And you can see in the red there, that's when you also take into account the unstructured data, so the text notes, and you can see the confidence intervals overlap, but the point estimate moves to the right. So you get sort of a stronger association there, right? Then if you move to the right, this is the same population and looking at rates of having an ED visit in the next year. And you actually see the opposite that happens. So in the blue, you see the structure data only patients have a strong association in terms of the point estimate with having an ED visit when you look at the ICD codes alone. Then when you look at the notes, you see a much tighter confidence interval, but it's actually a lower point estimate compared to having the ICD code alone. So it just goes to show it's the context of these can really make a difference, and it's not necessarily true that ICD codes are coding for the same thing as text notes, and that text notes might have some more nuance that makes it so these point estimates are slightly different than what the ICD code has. Yeah.
Is it okay to ask a question about this?
Yeah.
So would you say neither one is better?
I would say that's a good
I mean,
question.
obviously they have different pros and cons.
Yeah. No. Well, to be honest, I think you just have to know the limitations of each there. So I think the confidence interval, especially of the one on the right, shows you. So that confidence interval is so much tighter, and so it's much higher prevalence. So if you're looking at that, I think that's a better estimate of prevalence and probably the nuance of what. So there are more people where you actually were able to see it there versus on the blue is kind of like a much lower prevalence. So we think that more likely people in the blue with the ICD codes had the most sort of severe social sort of risk factors that were put there. So I think they both work. I'd say neither is better. They're both good to have in context depending on what you're looking for, because they're not necessarily wrong. Like they're both associated with prediction, but I think having both is ideal. But better to have one versus the than none at all. So I think, yeah, so I guess complicated way of saying neither is better. You just have to know what the question each one can answer. Yeah, and a lot of people, I will say, use the ICD codes for research because there's such a low prevalence. What they'll usually do is propensity score matching with big data sets to try to get a similar sample. So there are workarounds for the limitations. Now, with large language models, it's getting easier and easier to do the text extraction, so things will get hopefully easier for the unstructured data. Okay. All right, I'm going to keep going and we'll talk about awareness now and sort of how informatics can help with awareness. There's Nancy with her desk looking as clean as I've ever seen it. Which I always love about Nancy because my desk is messy too. And so Nancy and Bill Stead co-chaired a committee that published a report. There was part one was 2014, part two was 2015. This Institute of Medicine report, now National Academy of Medicine, that endorsed capturing social and behavioral determinants of health in EHRs. And they talk about several that they recommend all EHRs sort of and all patient encounters capture, including stress, social isolation, financial strain, among several others. So a lot of hospitals since then have been capturing, and with more and more interest from standard setting organizations, there's been a lot more interest. This is that same study that we were just looking at over time. Time to readmission, those in blue are those without the risk factors, and those with red are with the risk factors. And so, just awareness can help with risk prediction of who's going to be readmitted over time. And this is, since we talk about it a lot, these survival curves. So at the top, this is the percentage of patients not being hospitalized. So at the start of the study, 100% of them were not hospitalized. And then at the end, you can see the percent being not hospitalized is decreasing, i.e. the number of people being hospitalized is increasing. And so the closer the bar on the top has a number of people that, fewer number of people that are hospitalized, and the one at the bottom, red, are people that are getting hospitalized more quickly. So it can help with risk prediction, having this social information. In the EHR paper that Laura and Eric and I did, and Nancy, we were looking at using those National Academy of Medicine domains, time to onset of hypertension and diabetes, using Kaiser database, using their structured data SDOH module, and we could see that the higher number of risks, the more quickly people are being diagnosed with diabetes over time. And the same thing held true for hypertension. And so, you know, having this data there, if it's collected and if it's, you know, the more universally available it is, can help with risk prediction. But the challenges that exist to this still are sort of not only the types of data and where it's stored, but the variability. So Sahil Sandhu, who wrote this paper with Laura and me, was looking at sort of the survey of American Hospital Association survey. And what you can see here is it asked them, you know, how do people collect SDOH data in hospitals? And this was from their 2022 survey, I believe, or maybe it was 2023. So you can see there at the left, about 50% of hospitals collect data using a structured tool, like the modules I showed you. About, you know, 17% collect SDOH data using free text. About 20% use diagnosis codes, and I'm shocked to see that 8% still use non-electronic method. But even within that structured tool, to the point I was making earlier, you know, even if you have a structured tool, if you want to make comparisons throughout the rest of the country, or try to pool data to look at sort of national estimates or local estimates, you know, some people are using an established tool in orange, but others are using a customized tool in black, and others are using a combo tool. So in terms of how you can compare those, it's probably not going to be the same metrics across, you know, as if you were all using sort of the same sort of established tool. Other challenges are sort of user burden. So we know that instead of just typing in your note, or, you know, having something where you're saying it into the microphone and it's transcribing, clicking just adds burden. And Isabella and I are doing a, you know, an implementation evaluation of sort of SDOH tools in UCSF Health, and, you know, anything beyond 2 clicks is very hard to do, right? And so this was a paper done by Hillel, and they looked at a typical about 10-hour emergency department shift, and there were almost 4,000 clicks on average that people were doing, physicians were doing during that click. So to ask them to do more, you know, is a heavy lift. And so this also just goes to show that that people, if there are different ways of collecting the social needs, and that it's not all routine as well. So some people in this same AHA survey, so it's 2023, said that they collected SDOH data. Only 54% of them said that they would do it routinely, versus about 17% saying not at all, and some saying yes, but not routinely, for about 29%. You could also see that about 60% said they received social needs data, and 40% said that they don't. So in terms of interoperability, we still have a ways to go. Just to also show how the burden can happen in terms of structured versus unstructured. This was looking at UCSF Health data over a year, and looking at structured data capture versus unstructured among patients hospitalized over a 1-year period. And you can see, looking at the social work notes, this is how many patients who were hospitalized that had, it showed that 50% of them had social data documented in social work notes, either during that hospitalization or prior to that hospitalization. So by the time they were discharged, there was either a prior social work note or a new one. And you can see also in that on the right there, in terms of, this is the social history text session where you type in the social history of what's going on with the patient. There was also about 50% that either had some text prior to the hospitalization or during it. So at least half of them had some data there, but this is free text forms. Less than 1% had stuff clicked in these discrete data fields for SDOH. Again, this was 2019, so it was a while ago, but there was much less uptake of documentation in the structured forms versus the unstructured. So this just sort of goes to show why it can be hard to get people to adopt. This was looking at a study trying to get community health centers to adopt SDOH screening, and there was variation between 4 and 18%, something that Rachel Gold had done it, and Laura was on this paper too a few years ago. So, and even awareness in a paper that our fellow did, Brad, I had a few years ago, just asking clinicians in this survey in 2020 about, can your EHR collect SDOH data? 12% said they did not know whether or not it could. So it's not even whether or not they know how to use it. It's just, do they even know it's there? So lots of challenges to it, to collecting this in sort of digestible forms to help with different things like risk prediction and advocacy. So ways to overcome this that people have been working on, in terms of implementation science and just sort of design and Epic is sort of focusing on user design. What would be the best way to present the information to the right person at the right time? So you can see here, I know it's a busy slide, but you can see on our Epic here at UCSF and also at San Francisco General, what's called the storyboard, which is the left part there that has the patient name and it's sort of blue going from top to bottom. At the bottom there, you can see it shows these circles of SDOH. You don't have to read anything. You just look at a house. If it's red, there's housing instability. There are other visuals that you can go to these social drivers of health boards and see, what's red and what's green to let you know who's screen positive, negative. So trying to give visuals. And I would say when we interview people, for example, we were doing interviews at San Francisco General, maybe you're not looking at these all the time, but if on the bottom left corner of your eye, you see 8 red things, when you're used to seeing lots of gray, does it, do people say, I sort of look at that for a second and I'm like, oh, they might be facing some things. So these sort of visual cues to help the burden of the user. They've also developed different ways. So for example, you can put these, whenever we're in the hospital, we have our lists of patients and, I have my list of patients that I'm taking care of, their name, age, weight, allergies. And we also have these columns you can put in that says, do they screen positive for different things? At the bottom there, it shows, the words, but I just prefer to have the dots. Again, it's just less cognitive load, right? If I see a bunch of red, I think, okay, this person has some barriers that we should try to figure out what to overcome. And they even have one that says, if you screen positive for any, it'll turn red. So you can just put that one column instead of 5 of them and just look at it if it turns red.
Does the gray mean not screen?
Gray means not screen, and black means decline to answer, which is a whole other thing we're looking at. Okay, busy slide, but don't worry, we'll get through it. So this is actually looking at one of our quality improvement projects at the pediatrics ward at Mission Bay that I work on, and you can see, you can ignore a lot of things, but so in blue here is looking at financial strain screening. And orange here is looking at food insecurity screening. So the food insecurity screening, we initially only did if you screen positive for financial strain. And the workflow is that nurses screened everybody when patients were admitted for financial strain. And if you screen positive, doctors would screen for food insecurity. So you can see this is in the beginning here. It's just kind of all over the place, all this stuff. This is like probably when I'm on, this is probably when someone who doesn't care is on, this is when my friend is on, like it's all over the place. This, we can have education for the residents, education for nurses, all these different, the emails, all this stuff. And then we just have here, which is the sustained thing. And this intervention, which we still have, is we had the question, instead of having them click on those icons and ask the questions, we have nurses have to ask patients a set of about 20 things. It's a lot, when patients are admitted, your weight, allergies, all these things. And we just had them add the financial strain screening question to that. It's been, 90% or so since then. You can see here the doctors are still kind of doing terribly because we have, we're sort of all over the place, but the nurses you're getting everybody there when we included it in that navigator. And you can see here, this is looking at that same analysis, all of that stuff here. This is the inpatient nursing questionnaire. So about 88% of patients had these questions asked when nurses are asking them in this admission questionnaire. So just making it easy and more accessible, and so that you don't have to think about what you're doing. It just sort of comes after all the questions you're asking. Okay, now we'll get to adjustment. Not as much as an adjustment, we have some. In an AHA survey in 2022, leaders of hospitals said that about 72% of them said that they use SDOH data to inform discharge planning, and about 67% used it to inform clinical decision-making. And in the evaluation Isabella and I are looking at this, UCSF health staff, this is a pilot staff, about 148, saying that, the majority of them somewhat or strongly disagree that they use SDOH to inform medical decisions. So people are, doing this. We're trying to figure out ways that the EHR can help. Examples are, if you have unstable housing, collect multiple addresses, collect samples at the same day at clinic lab, or engage with social work early to address transportation needs. These are all examples that people in our interviews have been mentioning. Oh, oops. So I think this is I think the strongest slide related to adjustment I have with informatics thus far, but also it is not tell you exactly what's going on. So again, this is Brad, I led this work. So looking at time to readmission in a UCSF health sample, what we measured is looking at did clinicians look at and engage with through metadata? Did they engage with SDOH data? Did they click on social work notes? Did they click on the social history section? Did they engage with it? We don't know what was there, but did they engage with it? What we can see there is that on the top is people in red. This is patients for which the clinicians engaged with the SDOH data. The bottom, the blue, is patients where they didn't engage with the SDOH data. And you can see the people where they didn't engage with it, they're being readmitted at a quicker rate. We don't know what's happening exactly. It's just a signal, but there's something where people are engaging with this SDOH data and something that it's strongly related to sort of the rehospitalization there. So we need to learn more about what that involves and what sort of happens when people are looking at it and what other signals could be confounded by, but there is some relationship there. Yeah.
Can I interrupt you with that?
Yeah, of course. Yeah.
Do you have a sense that different types of docs and providers are engaging with the data and they're more motivated to do that, or do you think the actual act of engagement is
I think probably both. So there's certainly, it's the like 80-20 rule. There's like a lot of people, there are the people who do it and there are roles that are more likely to do it. But yeah, I think there's also engagement, quite honestly, was like kind of overall lower than we thought. So it's not like so it's not just a few people. There's like enough people doing it, but low users that are kind of right. But I think it's both. And certainly there are the people we are certainly still in like a high adopter super user phase. So there are those people that are engaging with a lot. And we have the data on the role type, so we should look at that. Yeah. So this is also just to show you the types of data that's reviewed. This is the same group that we looked at before with those blue graphs. So bear with me, the RR means the review rate. So if you look at the social work notes, remember there was about 50% that reviewed it. And then looking at that, of the whole sample, 35% of patients had those notes reviewed before discharge and 15% had data that was documented that was not reviewed or engaged with before discharge. So that's about a review rate though of 70% of social work notes, versus on the right, you can see the patient social history where you type that in. There's a review rate of about 29%, and then the others are still too low to really be any value. But it just goes to show, depending on where you put it, people are more likely to look at one versus the other. You see 70% versus 29%. So trying to think of where you would put this, probably want to go where most people are looking. Okay, assistance, I'm just going to keep going so we can get through. So there's lots of new tools that are being developed to help with referring patients to community-based organizations. This is how you can look up community resources in Epic, and you can find a list, and then you can select the diaper bank and put accept, and then it prints out in the after visit summary papers you take home. Siren did a nice report cataloging all of these a few years ago. Some of them you might have heard about Unite Us or Find Help or Find Connect. This is Find Help, the one that UCSF has purchased. So this is now in the EHR where you can type in a zip code. You can select a bunch of from a bunch of social needs, and then you can you can print out a list of local resources, or you can even click apply here and send stuff electronically if the patient consents. However, there's success of this to be a two-way communication system, because CBOs can then write back and say, we saw the patient. However, you really need to engage with CBOs early to do this. And we see that a lot of CBOs, and Caroline, I know, is on the call, has done a lot of work on this. The adoption rate among CBOs is low, and the adoption rate of two-way referral can be very low. So these at their best right now are kind of like lists of one-way referrals, but getting staff to use them and then getting users on the other end to use them, it's still sort of not very universal. That being said, when we did a survey of children's hospitals, we saw 60 children's hospitals a few years ago. About a third of them were using these online social referral platforms to address social needs. So they're being used more and more. But the barriers that we've been finding are platform limitations. They can be clunky. You need training, double documentation. So a lot of times you need to select things, but then if it's not integrated with what the patient gets in their printout, then you have to both select them and print them out. So it's what they call double documentation. Time is always an interest, and then also just patient interest, if they want these resources or not. So some of the quotes we saw were, sometimes things are happening really fast, so it's kind of hard to like sit and trial and error this stuff. I'd rather just sort of type it in. Or others say, I've never really found something to find help that I didn't find in Google. So they already know how to find something in Google. Why use this thing? That would make it easy for us to then look at the data and help for all these population health things, but on the day to day, it's going to be hard to get somebody to do this.
I remember kind of early on, one of the biggest challenges was with this was the having to kind of update the resources that like places would close,
Yeah.
numbers would be
Totally.
done, and like it was just
Yeah.
like this like really terrible
Still.
process of trying to get that.
Yeah, and that's basically what this is. So what's built into Epic is kind of a glorified spreadsheet. You have to update it, you put it in. It is like a
There is
spreadsheet.
no other
Correct,
better
but
way.
But that's what these platforms say that they will give you. They're
I
like,
see.
we will update it, we will keep it up to date. They're like, things will close, yes, but if you say this is now closed, we will update it within 48 hours.
Yeah.
They also have offices of people that are calling to see, are you still open and that type of thing. So that's what they're trying to give you is say, hey, we know it's hard to do this. Here's the list. Yeah. But absolutely, that was a huge barrier. And that's why at the general initially, they did not do this. So because of all these barriers, you can see in our pilot site of 10 sites, among patients that have social needs, we've thus far in the year of the pilot had 6.9% in the inpatient setting and 7.2% in the outpatient setting having documentation of getting resources using these platforms. Now, it's probably much higher, but documentation is just this. So again, trying to think of ways to overcome these barriers, we put QR codes in all of the after visit summaries so patients can just scan this and go to our UCSF branded site. To then look for things on themselves, by themselves, and we're not gatekeepers. We're trying to track this, so we could do a little bit better job publicizing it, I think. So this is looking at among patients screening positive for at least one social risk factor, 3.6% of patients scan those versus those patients that screen negative or that did not get screened. It's about the same rate, 1.6% of them scanned the QR code. So I think what this goes to show is we could probably do a better job of advertising it, or patients aren't that interested, so we need to find out more. Also, you can see here, I think it's probably the former, because this is looking at since we got Find Help, and really it launched in May 2024, but this is January on the left, and then up to last month here, you can look at in yellow are the UCSF branded website of Find Help. Yellow are staff accessing this and doing searches for things like food and housing. Blue are anonymous users, which represent non-staff. So actually, we think patients are actually using this and getting it. We're sending it out through a lot of different methods, through new patient appointments, the QR codes, that type of thing. So we think there are other ways people are getting it. So it might just be better to be teaching patients about this so they can do it on their own. And other things to help with this too is sort of triaging, social work's time to sort of help them. So for example, we now have a new question at the end that says, we make community resources available. Would you be interested in resources? Yes or no? And if so, which ones? So that you don't have to necessarily go to see people who have social risks. You only see them if they have social needs and actually want help. So trying to help our workforce with that.
I had a question.
Yeah.
For that one back.
Yeah.
Do you have any thoughts about why the big spike in August?
I think in August, a couple big pilot sites came on board is my best guess. I don't
So
know.
the increased engagement with them just
I
starting.
think possibly. And then I know in January after that, we lost a health navigator who was doing a lot of this work. That's my best guess for there. So it's, but it's a good, we're still trying to figure it out, sort of what those things are.
Are they adult?
Both. Adults, peds, inpatient, outpatient, ED, pop health. Going through the last bit here for alignment and advocacy, I think once you have this data, you can think of the things to do. Like this is looking at what are the commonly use CBOs in the pilot sites, so you can use that to sort of forge partnerships and also just see, are there things we can advocate for in the city to help promote. We can look at the types of things not only by searches, so this is looking at what are people searching for. So we could say, hey, people are searching a lot for food and housing. This is something that maybe we should have good plans to address, and also what they're getting referral types. So food and housing were the top there. Referral, food is a bigger percentage of these referrals here. Housing actually drops down to lower, and that might show you this disconnect between searches for housing and housing referrals might mean, hey, we need more housing resources, right? I mean, which we obviously need in San Francisco, but looking at both of these, you can see how you can use this in population health and to advocate in your health system, or, for SFDPH, it's the same pot of money supporting housing services as it is the healthcare system. So advocating for resource allocation at that level. When we talked to CBOs, we did interviews with 42 CBOs and asked them about these referral platforms, and most of them had not used them at the time, but they thought that actually the tool would be really useful for certain things, especially if they could use it to actually help refer people to other places as well. And they discussed how, though, will require some financial sort of help for staff capacity and sort of for training, that type of thing, but there was actually a lot of enthusiasm for them. And lastly, I just wanted to touch on a few ethical considerations as we're doing this, which again, Laura has been writing about with Hugh. How could integrating social medical care, especially using EHR, worsen health and inequities? You can use, Unfortunately, you don't need your imagination so much anymore with how things are now, but it used to be more imagination. But there are, lots of concerns and unfortunately real world examples. This one, for example, is looking at trying to leverage EHRs to help with figuring out which patients might benefit for this special case management plan for sort of very sort of quote high risk patients that might benefit for this to help with some of their health outcomes. And what they found is that actually Black patients were getting assigned as high risk less often, despite the same sort of health profiles initially. And they discovered that the algorithm actually took cost into account when assigning high risk, but because of a lot of barriers related to structural racism, the Black patients were accessing care less often, lower cost because of that. So then they were called non-high risk, and they were actually not eligible for this as often. So it's actually really, 10xing the harm to Black patients in this thing that was supposed to sort of try to help get patients sort of in this case management program. And our staff are certainly concerned about this in a classic bell curve. They're thinking, when we ask them, if you're concerned about collecting this information can contribute to bias or discrimination, and there's a good amount that are, some that aren't, but it's certainly something that has come up in our interviews with both staff and patients about their concerns. And you could see here in the study that Amelia and Danielle and Laura did years ago, and Eric did as well, and Nancy, everybody. You could see here that on the right, this is the percentage of patients that are somewhat or very uncomfortable with SDOH data being put into the EHR. You can see it's about 20% in sort of emergency and primary care settings there. We continue to do qualitative interviews sort of exploring these issues. Questions that come up with all this EHR data is, how do we prevent health insurers from penalizing patients because of social factors? How long should this information live in the EHR? And what sort of safeguards should be put in place? For example, adolescents, when you're doing certain types of assessments in healthcare, their notes can't be accessed by parents. Should we have, social notes that should not be able to be accessed, depending on if the information might be used for harm? And so these are the types of things that we're sort of grappling with. So the take home points today, I tried to get across are that do you think social drivers of health data stored in the EHR can help integrate social medical care, can help with risk prediction, certainly, understanding the social context to help tailor medical care. And then it does have the potential to connect and collaborate with CBOs, although we're still sort of on the early phase there, and certainly can help understand your population needs if you have, sort of uniform data collection. If when implementing these programs, I think the key take home that Isabella and my work has been showing is that you just should take end user preferences into account, if you're gonna get any adoption at all. And just for always when introducing this technology, thinking about how ethical challenges may come into play and how health systems and policymakers should be aware of them as sort of this field is advancing. References, easy to read. And then thanks to everybody for their help in this. Lots of people in this room, so I really appreciate it.
Questions? I don't know if there's any questions on Zoom, but we'll take them up.
Hi, thanks. Great to see this. I was wondering if you have looked into other BHRs, like in addition to UCSF. Good to see if it's generalizable.
Yeah, we've looked at, I'm trying to think for which projects. For the ICD code, like structured data documentation, we've looked at lots of EHRs. For the relationships to health outcomes, our team hasn't merged it, but others have looked at similar associations and risk prediction. Now with the engagement, I don't know of others that have looked in the engagement, which we're trying to see others that can, because certainly, and sort of like to Nikki's point, like different health systems that either, I don't know, if value the work more or just not even value it. If they have more standards of screening and are more adamant about doing it, you know, they might have different implications for engaging with it or not. So we'd love to sort of look more into that and trying to see with other health systems.
This is totally anecdotal, today at Kaiser, and they just started asking
Oh, yeah.
these questions.
Yeah,
Yeah.
totally. Yeah, Kaiser, different Kaisers have been doing it in certain settings, actually, like that Kaiser, that paper, the onset of diabetes, that was, I forget. Eric, where was that? Was that Oregon? I forget where that was. Was it here? Oh, it was here.
Yeah, but
so
it was like,
it was certain clinics.
yeah,
Clinics doing it.
it was definitely like the research arm.
Yeah,
of some
totally, the
sort,
research
so-
arm, yeah,
But
yeah.
you're right, so I have another June, I just got like a
Mhm.
survey in the mail.
Yeah, like literally today.
Yeah, there you go. See,
Good partnership.
Yeah, right. Yeah, right. Yeah, take a look. They have it.
Two quick things. One, just an incredible body of work, and I hope what you guys have picked up, especially those of you guys who are maybe a little earlier in your careers.
This is a journey that Matt's been on. I mean, Matt came in as a resident and then as a fellow and was doing his little side projects related to some of this stuff. And then like this has this portfolio of research that's so complex and multi-layered and in all the ways. It's just so impressive to see the scope of your journey here and how high impact the work you do is and has the potential to keep growing to be. So I just wanted to call that out. And then the other thing to ask you about is, it's so interesting how separate the social drivers of health work is from the PEARLS or ACEs screening work. And yet they're like 80% overlapping in concept, goal, et cetera. They're slightly different content, but the PEARLS screener, which is like a childhood adversity screener along with some other social drivers. And I don't hear you guys ever, I know there's some, background for some of that, but it's also striking how little conversation there is among the strategies that the state of California has been using around ACEs screening implementation versus social drivers, which is more national. And is there room for that to have more like leveraging each other's efforts and learnings, do you think?
Oh, yeah, I think absolutely, especially because PEARLS, has social driver, you know what I mean? Like, and I know certainly at the research level, it's been tough because it's just less commonly done ACEs, except in California, where we have been looking at it. And that's a whole other talk about that. But certainly I think at the operations level, which I wear a few of those hats for now,
Yeah.
is certainly there's discussion about it. And I think unfortunately, fortunately, because in California, there's been a lot of policy incentives for it. I think that hospitals, especially in the context of this year and the next 3 years, have fallen back on less of what they would like to do and more of what they have to do. And so it's sort of being driven by what standards are sort of there. But certainly at the operations level, leadership, especially in the children's hospital, and even though I know, and we all know that ACEs are important, especially to adults, But the Children's Hospital, there has been advocacy and pushing for that on an equal footing as the SDOH screening. So
You're
certainly,
doing so much great work.
Totally,
It's just- You're
yeah.
learning so
Matt,
much.
can I, would it be okay if I just jumped in for 2 seconds?
Yeah.
Sorry, Nikki, I don't know if you guys can see the chat, but I just threw in a paper that our fellow India wrote that was really looking specifically at perspectives on the similarities and the big differences in terms of implementation of ACEs screening and social determinants of health screening in community health centers. And so I just threw it into the chat, but there are some really important differences conceptually in terms of like the look back period and present versus versus past, and then also just like what the intervention scope is and who needs to be at the table. So she like describes those, and then she talks conceptually and practically about what the implications are. So that might be a useful reference. But I otherwise 100% agree with Matt that there are opportunities to integrate, especially like policy level, and California's I think been ahead of the curve on that. And then before I jump off, because I have an 11 o'clock, Matt, this was awesome. It was so fun to see what an incredible breadth and depth of work you've done. And so thank you for sharing it.
thank you for supporting all of it, everybody here.
Great talk.
All right, yeah. Amazing work. I just want to put a plug for the next Coffee and Science, which is October 14th, and we'll have several short talks from the Nancy Adler Seed Grant awardees. So I hope you can join us then. Thanks.
And when is the Adler Symposium? I hope you all can come.
October 24th.
There's a save the date for that, right?
Yeah.
There is a save the date, but is it on your calendar? I hope so. It's gonna be great. We're gonna have the former president of UC speaker.